وَلَقَدْ يَسَّرْنَا الْقُرْآنَ لِلذِّكْرِ فَهَلْ مِن مُّدَّكِرٍ.
Today we are going to learn local anesthetics. What are the objectives? Now we will recall how action potential is generated and propagated. We will learn what are the types of local anesthetics, what is the mechanism of actions, what are the pharmacokinetics and toxic effects of the local anesthetics, and what are the different techniques available for the local anesthetic drugs. Lastly, we will discuss the risks and benefits of using the vasoconstrictor with the local anesthetics. So what are local anesthetics? Local anesthetics produce a transient and reversible loss of sensation that lead to analgesia without the loss of consciousness. We can say simply, local anesthesia refers to the loss of sensation in a limited region of the body. It is accomplished by the disruption of the efferent neural traffic, and here we inhibit the impulse generation or propagation. This will be completely reversible. The main point is that there will be a muscle paralysis, there will be resuppression of somatic or visceral reflexes, and there will be analgesia. So, if there is a loss of sensation, if there is no loss of sensation, at least there will be the achievement of the localized analgesia. Structurally, if we classify anesthetics, there is a lipophilic group and hydrophilic group, and these groups are linked either by amide linkage or ester linkage. It is a common structure. You can see this is our aromatic group. This is the amine chain along with nitrogen, and this is the intermediate chain with the linkage of the amide or ester. So on this basis, we can say that we have two types of the local anesthetics, esters and amides. Aromatic group will increase the lipophilic nature of the local anesthetics, while amine group will add up the hydrophilic characteristic of the. Here you must know that ester links are more prone to the hydrolysis as compared to the amide linkage, and due to this, esters usually have a shorter duration of action. What are the other characteristics of the local anesthetics? Mostly, they are weak bases. They are water insoluble. If we convert them in a salt, as they are available clinically, it will increases its solubility and stability. You can say that HCl salts are acidic and water soluble. When they are metabolized in the body, they exist either as a charged form or uncharged form. In tissue, at 7 pH, they will hydrolyze and they will produce its effects. The most important thing is the presence of the local anesthetic in a cationic form, which is considered as a most active form at the receptor site. But the problem is that this cationic form is impermeable to the biological membranes. So, for the penetration in the biological membranes, local anesthetics must be in the condition in uncharged form so that it will reach at the site of the action. We need the relative proportions of two forms, and these relative proportions are governed by the balance of the pKa and the pH of the body. Uncharged form is very important for the cell penetration. When it is penetrate in the cell, in the cytoplasm, it will undergo the equilibrium. It lead to the formation and the binding of the charged cation at the sodium channel, and hence it produces a clinical effect. If local anesthetics are injected in the infected tissue, the low extracellular pH favors the charged form, while less of the neutral base available for the diffusion across the membrane. अगर हम प्योर फॉर्म में देंगे और वो कैटाइनिक फॉर्म होगी तो फिर वो सेल के अंदर पेनिट्रेट नहीं होगी, डिफ्यूज नहीं होगी ड्रग. This is the main reason that usually local anesthetics के साथ we will add a bicarbonate. Bicarbonate is added. Sometimes that will effectively increases the concentration of the non-ionized form. Non-ionized form की concentration बढ़ा देगा and that will shorten the onset of the regional block. Regional block के लिए हमें bicarbonate इसमें add करना पड़ेगा. pKa and pH is very important and ideally for basis if the pKa is higher, the greater will be the ionized fraction in solution. According to the Anderson-Hasselbalch equation, log of A divided by AH is equal to pH minus pKa, and here A is the ionized form and AH is the non-ionized form. Diffusion is directly proportional to the non-ionized form, so local anesthetic with low pKa have a fast onset of action. Local anesthetic with high pKa have a slow onset of action. यानी अगर pKa low होगी तो onset fast होगा, ये penetration fast. Non-ionized form में रहेगी drug, penetration बहुत fast है और फिर टिश्यू के अंदर जाके वो इक्विलिब्रियम कर लेगी. और अगर pKa हाई है फिर फॉर्म जो है वो नॉन आयनाइजेबल की बजाय आयनाइज ज्यादा है, इसकी वजह से ऑनसेट स्लो है. फॉर एग्जांपल you can see that lidocaine at pH 7.8 has fast onset in comparison with bupivacaine because at this pH greater proportion of lidocaine exists in the non-ionized form. अगर ये non-ionized है तो फिर ये ज्यादा टिश्यू पर पेनिट्रेट करेगा और बुपिवाकीन की जो पेनिट्रेशन है वो लेस होगी, स्लो ऑनसेट है. बुपिवाकीन is existed in the ionized form, reducing the amount of the unionized drug available to cross the nerve and provide the anesthesia. It is very important. So bicarbonate is added to speed the onset of epidural anesthesia as bicarbonate will facilitate the non-ionized. Lower the pK, the greater the percentage of the uncharged species at the given pH. Fortunately, pKa of most local anesthetics are in the range of 7.5 to 9.0 and there will be the equal proportion of the charged and the uncharged cationic form. There is an exception of the benzocaine which has pKa around 3.5. This exists solely as the non-ionized form under the normal physiological condition. What are the pharmacokinetics? Usually, local anesthetics are less effective when they are injected into the infected tissue because of the low extracellular pH that favors the charged form. There is less of the neutral base that causes the less diffusion across the membrane. If we talk about absorption, there are various factors that are participating in the absorption of the drug, like dosage form, site of injection, drug tissue binding, local tissue binding, and use of the vasoconstrictor, while physicochemical properties of the drug itself. Those anesthetics that are more lipophilic in nature, they are more potent and they have a long duration of action and they will take longer time to achieve their clinical effect. Furthermore, if they are extensively protein bounded, then it will also increase the duration of action. If local anesthetic is administered in highly vascular areas such as tracheal mucosa or tissue surrounding the intercostal nerve, that result in the rapid absorption and higher blood levels will be achieved. Here, what we require is that the drug will slowly absorb in the blood and the steady state concentration in such a way that minimum effective concentration will not reach in the blood. If we administer the drug in a highly vascular area, it will result in the rapid absorption and higher blood levels and there will be more toxicity. If it is administered in intercostal muscle, there will be the highest rate of the absorption of the drug in the blood as compared to sciatic and femoral. To reduce the absorption of drug in the blood, usually it is given along with the vasoconstrictor just as epinephrine that reduces the rate of systemic absorption and diminish the peak serum levels. And this effect is very evident in case of short-acting, less potent and less soluble anesthetics. As far as they are administered directly at the site of the target organ, the distribution within this compartment plays an essential role with respect to the achievement of the clinical effect. Distribute होगी drug तो ही अपने effects दिखाएगी, and mostly anesthetics are delivered in the subarachnoid spaces that will be diluted by the cerebrospinal fluid. Specific cavity is also play a role that related to the CSF along with the patient position. Functions are sometimes termed as hyperbaric, isobaric, and hypobaric, as well as respectively. Descent remain relatively static or stand quickly within the subarachnoid spaces due to gravity, and the patient is set upright. Usually, about 25 factors are there that can participate in the changing in the distribution of the local anesthetic, which CSF is the main factor. If we talk about the systemic absorption, the peak blood level achieved during the major conduction anesthesia, and that will be minimally affected by the concentration of anesthetics or the speed of injection. अगर अल्फा फेज की हम बात करें तो it will reflect the rapid distribution in the blood and especially in the highly perfused organ, for example brain, liver, kidney, characterized by a steep exponential decline in the concentration. शुरू में अल्फा फेज में ब्लड में भी हाईली लेवल्स अचीव हो जाएंगे एज वेल एज जो हाईली परफ्यूज ऑर्गन्स है वहां पे भी कंसंट्रेशन अचीव हो जाएगी, बट वी हैव टू मिनिमाइज इट. Initially, start में होने के बाद there will be a slower decline, beta phase, that reflecting the distribution into the less well perfused area, for example muscle and gut, and here there will be a linear rate of decline. If we talk about the metabolism and excretion, amide local anesthetic are converted to more water soluble metabolites in the liver or in plasma, either amide type or ester type, which are excreted in the urine. Some local anesthetics remain uncharged and they diffuse readily from the lipid membranes. Little or no urinary excretion of the neutral form occurs. If we acidify the urine, it will promote the ionization of the tertiary amine base to the more water-soluble charged drug, leading to the more rapid elimination. As far as ester type local anesthetics are considered, they are immediately hydrolyzed, especially by the butyryl choline esterase present in the vessels. They inactivate the local anesthetics, especially procaine, fluoroprocaine. Their half-life in the plasma are very less than a minute. However, if they are accumulated in the patient, it will reduce or upset the plasma hydrolysis secondary to the atypical plasma choline esterase. As far as amide local anesthetics are considered, they will undergo the complex biotransformation in the liver that involves the hydroxylation and the alkylation by the liver microsomal enzymes. There is a considerable variation in the rate of the liver metabolism of the individual compounds. For example, pilocaine are fastest metabolized, then lidocaine, then mepivacaine, and then ropivacaine and bupivacaine. And levobupivacaine are those compounds, those local anesthetics which have a slowest metabolism. As a result, toxicity of amide type of local anesthetics are more likely to occur in patients with hepatic diseases. Average elimination half-life of lidocaine is 1.6 hours in a normal patient, and it will increase up to 6 hours in the patient with severe liver diseases. Furthermore, if the patient are under the anesthesia, several drugs are metabolized by the same P450 isozymes, and their concomitant administration will lead to the competition of the drug that lead to the slow hepatic metabolism of the local anesthetics. Furthermore, if there is reduced hepatic blood flow, again local anesthetic elimination will also decrease. The hepatic elimination of lidocaine in patient anesthetized with the volatile anesthetics is slower in patients anesthete with IV anesthetic techniques because because it will impair the hepatic blood flow. In case of congestive heart failure, there will be impairment of the hepatic blood flow that lead to delayed in the metabolism of the lidocaine. It is the comparison of the peak blood levels of several anesthetic agents after the administration into various anatomic sites. Here you can see that bupivacaine has highest half-life, that is about 28 minutes, while if we talk about the elimination half-life, it is 3.5. Volume of distribution is 72. Highly lipid soluble drug, and it is amide, so it is metabolized by liver. Its clearance through kidney is just 0.47. Lidocaine, bupivacaine, prilocaine, and bupivacaine has these effects. Among them, the volume of distribution of lidocaine is very high, and prilocaine has 261, which is a maximum volume of distribution. What is the mechanism? Mechanism will be discussed in the next lecture. Thank you.